All right, next we have Dr. Celestia Higano. She was formerly a professor in the departments of Medicine and Urology Division of Medical Oncology at the University of Washington and the Clinical Division of the Fred Hutchinson Cancer Research Center. She is an adjunct professor in the departments of Urologic Sciences at the University of British Columbia, and she previously was the medical director of the Prostate Cancer Supportive Care Program at the Vancouver Prostate Cancer Center back in 2013. Dr. Higano is an internationally renowned expert and clinical researcher focusing on prostate cancer. And at UW, she led the prostate cancer clinical research groups that participated in developing agents such as zoledronic acid, sipuleucel-T, enzalutamide, apalutamide, abiraterone, and radium-223. Over the years, her clinical research has impacted the standard of care for prostate cancer patients around the world. So without further ado, here's Dr. Higano.
So I'm going to talk about the side effects of androgen deprivation therapy today. What are they and how can they be managed? And I'd like to do this in the context of the program where I'm medical director called the Prostate Cancer Supportive Care Program. So you can see how we use education in the context of this program to help patients and families manage with these side effects. So first of all, the Prostate Cancer Supportive Care Program, and this is the website listed here, is comprised of 7 modules, which encompass the whole range of situations for someone with prostate cancer, ranging from early diagnosis towards developing metastatic disease. And each module is optional for patients to attend. So depends on their situation and what they really want. So Module 1 is actually a module teaching patients about prostate cancer and the primary treatment options. Module 2 has to do with sexual function and intimacy after treatments. Module 3 has to do with exercise and nutrition, so-called lifestyle management. Number 4 is recognition and management of side effects of androgen deprivation therapy that I'm going to address today. 5 is about pelvic floor physiotherapy for urinary incontinence. 6 is emotional counseling. And 7 is an education session about metastatic disease. And why am I having trouble with this? Okay. So androgen deprivation therapy, well, what is it? Well, first of all, we know that testosterone is the main male hormone. And we know that prostate cancer cells are stimulated by testosterone. Way back when Dr. Huggins discovered that if he removed the testicles of which make the testosterone in men who had pain related to metastatic prostate cancer, the pain was magically relieved. Removal of the testicles was the only way to deal with that until the 1980s, when we finally had medical treatments to lower the testosterone to the same level as what we see with removal of the testicles. So testosterone has a lot of different functions, and this slide is sort of showing all of the places in the body that testosterone can have an important effect. So how can we control testosterone levels? Well, I already alluded to one of them. One is we can remove the testicles. And also now, luckily, since the early 1980s, we've had more medical approaches to that, which include any of the following injectables. And I've put both the generic name and the brand name, so you may recognize one of these if you're on one. There's also another way to lower the testosterone level. These drugs are more recent, these antagonist drugs. Degarelix or Firmagon is an injectable, and that's been around for a while, but just a few months ago, an oral form of this antagonist became available called Relugolix. So there's another option for men who need to have ADT or androgen deprivation therapy. So Again, just to quickly review, when we remove the testicles with a so-called orchiectomy, we're actually removing the place where the majority of testosterone in a man's body is produced. Otherwise, when we give the injectables, either the agonist or the antagonist, we basically turn the testicles off through this hormonal mechanism. So when we have, a person who's been treated with either surgery or radiation, we have these kinds of side effects, which, many of you may know well. When we then add androgen deprivation therapy, we're kind of adding insult to injury, because really when you put these together, there's a lot of overlapping issues. And so, it's really important to address these and know about these beforehand so you can be prepared on how to deal with them. So I like to think of the side effects of ADTs in these categories. First of all, what the doctor commonly will tell you, and there's three things, and we're going to discuss these. They talk about loss of sex drive or libido, erectile dysfunction, hot flashes, and that's commonly the only thing you'll hear from the doctor. Now, sex drive, unfortunately, as many of you may have found out, there is no magic pill to improve your sex drive or libido. We also know that in many men, as they age, not all, but many, the libido tends to decline anyway. There are very interesting strategies to actually enhance your libido. And we work on this with our sexual health nurses in our so-called second module. They look at all these different strategies for improving libido. So if your libido is kind of blah or none, usually you don't like to have good erections. And furthermore, if you've had surgery in particular, you may not have too good erections to begin with. So, we know that there are various treatments for so-called ED, erectile dysfunction, medications, vacuum pumps, penile injections, etc. With our sexual health nurses, we incorporate couple-based coping and education, some psychological and relationship counseling. But one of the things that's very important, and many patients, never mind many physicians, do not know this fact, that just because you cannot get an erection does not mean you cannot get an orgasm. So many couples will experiment with that and how to best allow orgasms to occur, if that's something that you want as a couple. So hot flashes. So this is another thing that doctors will tell us about when we're going to go on hormone therapy. A lot of times people think they got through the first month and they don't have any of these side effects. Well, oftentimes these side effects don't even really start coming on until the second month, because many of these drugs do not cause the testosterone level to go down to that, undetectable level until the end of the first month. So just because you're in your first month and you have side effects, don't assume that's going to be the same throughout the course. So what kind of things makes hot flashes worse? Various dietary substances like alcohol, spicy food, caffeine. Heat makes hot flashes worse. So, try to stay cool and well hydrated. And then stress, okay? Being in the middle of a traffic jam on the freeway, that's a sure thing to bring out hot flashes. So what can help with the hot flashes? Various materials. Anybody whose wife has gone through menopause knows that there's certain kind of materials that are desirable when you're having hot flashes. Also, sleeping with layers of clothing can be helpful so that you can take them off, and use a fan. I mean, my husband not only sleeps with the window open, but he sleeps with the overhead fan, and he's not even on ADT. So Anyway, massage and acupuncture has been shown to be helpful. But also, and this may be a little bit counterintuitive, exercise can help hot flashes. And so can something called cognitive behavioral therapy, which can really help with that. Now, there's a variety of things that people try. I would say most of these things don't have, much data behind them to show that they work with certain frequency, but some people seem to benefit. Maybe it's a placebo effect, I'm not sure. But these things shouldn't be added to your regimen without really talking to your doctor, because some of these items can actually interfere with medications you're on. But there are medications that do have some proven benefit for treating hot flashes. Gabapentin is one. Venlafaxine is another. And the nice thing about venlafaxine is not only does it help hot flashes, but it also can help with some of the depressive symptoms that some patients will get, which I'll address later on. Then the next category is, what do you see on yourself when you're treated with ADT? So let's talk about that. We're going to go into these things in detail. So weight gain can be a real problem. First of all, more than 40% of men are already overweight at the time they're diagnosed with prostate cancer. So if you're going to start ADT, this is likely going to get worse unless you do something about it. It's very common to see people gain 10 kilos, so that's 20 pounds, over 6 to 9 months, related to increased appetite and probably other metabolic changes that are shifting calories to fat instead of more productive places. This fat comes on, as you can see in this patient right here, around the waist, hips, and thighs, sort of more like, feminine types of body fat tend to be, and even in the breast tissue. And this is associated with loss of muscle mass and strength. And this, even if you are going to be on androgen deprivation therapy for a limited amount of time, it's often very difficult to lose the weight, even if you stopped the ADT. So that is very important. So we counsel people to be physically active with both aerobic and resistance exercises, and engaging in healthy lifestyle habits. So that gets us to our module 3 education sessions, where we talk about both exercise and good nutrition. Shrinkage of the penis and testicles. This can be very disturbing if your doctor didn't warn you about it. And I certainly had patients come to me early in my career wondering if everything was going to disappear into their body. And so this has to be discussed, that this could happen. Again, sometimes penis length is already less because of surgical retraction. And then when you add weight gain and all that, that just can make it even worse. So this kind of change usually stops after a year to a year and a half of starting ADT. But there are some strategies that might be helpful in minimizing this effect when you work with a sexual health clinician. What about hair changes is another thing that you can see. Commonly, there's thinning or loss of body hair on the trunk, arms, and legs. Beard gets softer, and sometimes some men say they don't need to shave. Some men think it's great, and other men are really bothered, especially by the loss of that nice chest hair that they used to have. Clearly, this is not a health issue, but it can be distressing if the person is not informed that this could happen. And this is one of the more easily reversible side effects when ADT is stopped. And what about what you don't see? So there's a whole list of things that you don't see. So one of them is bone density. We can't feel or see our bone density, but we know that hormone therapy lowers your bone mineral density and causes an increased risk for fractures. And many men already have low bone mineral density before starting ADT, but we don't usually think about it. We think about low bone mineral density associated with women who've gone through menopause. And then when you add loss of muscle mass and strength, and even balance with risk for falls, patients under these conditions can be at much higher risk for fractures. So loss of bone mineral density does not just stop magically either. It just continues while patients are on ADT. So to mitigate that, we commonly recommend a combination of calcium and vitamin D at these doses. Going up to high dose vitamin D is not a good thing to do unless your doctor is monitoring your vitamin D levels. So the same thing with calcium. More is not better. So, I know Dr. Moyad commonly talks about some of these things in his talks. I'm not going to belabor that, but just the message is more is not better, but it's when on ADT, it's good to take a combination. We know from testing that some men are at increased risk for fracture, and so those patients could be treated with bone building drugs, either once or twice a year, depending on what drug your doctor picks. But again, resistance exercises, meaning weights, bands, whatever, and high impact exercises also help preserve bone mineral density. The way we measure bone mineral density is with a DEXA scan, which is a very easy scan. There's no IVs. You don't have to fast for it. You just lie underneath the DEXA scanner, and it will give out a reading that your doctor can determine whether you have normal bone mineral density or whether you have low bone mineral density to start with, so-called osteopenia, or actually if you happen to have osteoporosis, and men do have osteoporosis just like women. It's just usually its onset is about a decade later than when we usually see it in women. What about diabetes and cardiovascular disease? Well, this is a nice large study that showed men of equal ages in groups that were treated or not treated with androgen deprivation therapy. And you can see that in the red, those treated with androgen deprivation therapy have more diabetes, cardiovascular disease, heart attack, and sudden death than the men of same age who are not on ADT. So it's very important to know what your cardiovascular risk is. In other words, have you already had some of these even before starting ADT? That may impact what drug your doctor chooses for you. Okay, and so metabolic syndrome is when you have 3 out of these 5 things going on: low HDL cholesterol, high triglycerides, visceral obesity, meaning in the abdomen, insulin resistance or hypertension, high blood pressure. So 3 of any of those things is metabolic syndrome. We know that when we treat men with ADT, fat masses increase, lean body mass or muscle mass decreases, insulin levels go up, lipids can go up and down. It's not always predictable, but oftentimes it's not in good direction. High blood pressure, hypertension tends to get worse. Blood sugar levels tend to get worse. And patients commonly have some level of low blood, and this says the mechanism is not clearly understood. Actually, that's not true. The mechanism is understood. It has to do with lack of testosterone, which is well known to stimulate the red blood cell line. So as doctors, we like to encourage our colleagues who are prescribing ADT to think of the ABCDEs that we should be preemptively thinking about. So A stands for awareness and aspirin. So, and as a patient, you can be proactive about this. Talk to your doctor about metabolic syndrome. Some patients may benefit from the addition of low dose aspirin to their regimen. Blood pressure should be taken. Your doctor should know where you start and whether or not ADT impacts your blood pressure. And if it does, you should be treated with it, not just wait until you go off ADT. Cholesterol and cigarette smoking. Again, those cholesterol levels or so-called lipid panels should be tested prior to starting ADT so they can be followed and treated with medication if needed or diet, depending on what the situation is. And certainly if you are a cigarette smoker, it would really benefit you to try a smoking cessation program. Again, diet and diabetes, follow a healthy diet. We frequently are sending patients to a registered dietitian, monitor your weight, and have your blood sugar levels followed. And then exercise. There's various recommendations currently in the United States. The recommendation is by the American Society of Sports Medicine, I believe, recommends 150 minutes per week of moderate to vigorous exercise and 2 to 3 resistance training sessions per week. So that just gives you a guideline, but you may need further input on how you could accomplish that. And then finally, the last category of the side effects of ADT has to do with what you actually feel. Okay, so we've gone through what the doctor tells you, what you see, what you don't see, and now what you feel. So let's go on to talk about that. So it is not uncommon that patients will complain of ADT-associated muscle aches and pains. Exact mechanism of that certainly is not clear to me, but it might have something to do with muscle wasting and changes in the tendons and ligaments. There are some non-drug related ways of dealing with this, like, again, exercise. I mean, you see the theme. Sometimes acupuncture helps with these aches and pains. And then the other thing that I think we don't emphasize enough is really getting some stretching in. I mean, I don't care what you call it, yoga, Tai Chi. There's any number of ways you can do stretching. And probably, even if you weren't on ADT, as we age, it's probably a good thing to be doing stretching anyway. So what about pharmacological? You can use non-steroidals and other drugs such as Cymbalta. I won't belabor that, sorry, because you can walk into a pharmacy and find that out. Now, depression, again, is something that you feel. And it's really important to understand that it's not uncommon for men to have what we call emotional lability after starting ADT. What is emotional lability? It means your emotions can fluctuate, be up and down, and even have kind of a short, or I should say shorter fuse than maybe you had beforehand. We know that major depression has been described in up to 13% of men who are on ADT. And we also know that this is about 8 times higher than in the general male population in that age range. If you have a prior history of depression, maybe you had to take medication, therapy, maybe you were even in the hospital, we need to pay attention to that at the beginning of starting ADT, because it might want to actually work with a therapist to follow that very closely. So again, sometimes medication, exercise, again, is always a good thing to do. And I'm just advertising, in our module 6, we have counseling services needed. Now, what about cognitive function? This impacts probably a smaller number of patients. It typically has to do with spatial memory, like where did I park my car? What did I do with the keys? Or, so those kinds of things. Again, exercise is really good at helping maintain a cognitive function. And then there's other sort of, things that you can do to help sort of clear out your mind, but also clear out your environment by decluttering living spaces, reducing alcohol, and possibly other depressants. Now, fatigue is actually it's not really exactly a very good description for what men describe, I would say. I mean, there seems to be somewhat of a lack of initiative, weariness, tiredness that doesn't always improve with rest. So it's not like the kind of fatigue you get from like a long bike ride, let's say. Sometimes it can affect people's ability to do the regular things they're used to doing each day. And contrary to popular belief, there's really no good medication that's known to effectively reduce fatigue. But we do know, again, that exercising really does improve fatigue, social functioning, mental health. And this is what I mentioned earlier about the kind of exercise that's recommended. But, I think we really, really underestimate the effects of exercise on the brain. And so I just want to, show this list on the right to show all the things that have been actually shown in studies that have been published where we see the benefits of exercise on brain functioning. And then on the left is sort of all of the other things that exercise can help improve, all around. So, exercise is an important thing. Now, I've been talking about the regular forms of hormonal therapy, and we have a lot of new agents now. These drugs, enzalutamide, apalutamide, darolutamide, abiraterone, are the newer second generation antiandrogens that have all been shown to improve overall survival in men with metastatic castration-resistant prostate cancer, and even in some other settings as well. So it won't be uncommon that these drugs may be added on to the ADT that we've been talking about. And certainly we know from the clinical trials that there are some issues. I mean, these drugs also have side effects, including fatigue more prominently in the top three, but also issues with high blood pressure. Enzalutamide, for example, has a small increased risk for seizures, but also patients seem to have falls more, and whether this is related to just more weakness in their muscles or to some central nervous system issues, we don't really have a handle on that right now. Apalutamide, the most common thing is a rash, and it sort of separates it from the other drugs listed here, but it's usually a pretty controllable rash. It's not really a game stopper for most patients. And low thyroid function, and again, high blood pressure. Darolutamide, of the three second generation antiandrogens, is probably the one with the least side effects. But having said that, none of these have been compared head to head, or at least published data yet to actually show that. So, I mean, I say that with a grain of salt. And then abiraterone, which is not a second generation antiandrogen, also has some issues with high blood pressure, more cardiovascular disease, liver problems, et cetera. So, it's a lot more complicated story than it used to be when we just were dealing with regular old ADT. So the take-home message is really that ADT can have many side effects, although most men don't have all of them, and even up to 20% of men don't have any of these side effects. So I think it's really important to try to deal with these side effects proactively, and try to avoid the long-term or minimize at least the long-term side effects of ADT. And if you didn't get the drift, I mean, probably exercise and physical activity are the most effective treatments that could cover most of the sins, if you will, of androgen deprivation therapy. It's important for patients to be active participants in these prevention strategies. And, to that end, I would suggest reading a book I recently finished called Keep Sharp by Sanjay Gupta. It really is very inspiring and might help you get off the couch if you're on ADT. In Vancouver, we have our prostate cancer supportive care program to support patients through these changes anywhere in the sort of prostate cancer journey. And the website is accessible. Our talks, many of our education sessions are online. This is a team that makes it possible in Vancouver. And yeah, I really enjoy working in this area. I don't see patients there, but it's a really nice program that patients appreciate. So thank you very much for your attention on that.
Hey everyone, it's Alex and Hunter from the PCRI. He has his own Instagram now, Sir Hunter the Dow, so go ahead and check him out for prostate cancer information and men's health. Huh, do you like it? Yes, say come follow me. And don't forget to subscribe to our YouTube channel. We come out with new prostate cancer videos every week.